I will now request Dr. Swati to please share her experience with the eager crowd.
Good morning, everyone. Thank you, Siddharth. Thank you, AIOC, for giving me this opportunity. So, I'll be talking about woos of the GATT learning curve and how to beat it. Most of my things have been covered in part by Dr. Ganesh, so it will be an overlap. So, as Sir said, prerequisites for any mix are sound anatomy, sound knowledge of angle anatomy, suitable surgical gonio lenses in your armamentarium, direct mastery over direct and indirect gonioscopy, because you need because it is not the thing which we practice day in and day out. So we have to take a time out at the end of the OT, do some intra gonioscopy on our FICO cases. Most important, you should have a tiltable microscope. If you don't have a tiltable microscope, it is very difficult. Also, you should have an adjustable table, so that the the table height can be adjusted. And also, to have the head end of the table elevated, you should have the tiltable table also. So microscope also should be tiltable, table also should be tiltable, and also you should have a mastery of the microscope foot pedal, because both the hands will be engaged in doing, one will be holding the lens, another one will be feeding the suture, like that. So ambidexterity, we all are ambidextrous now, and we should have lots of patience. As Mahesh said, practice is very, very important, and patience is also very important. Prerequisites for suture GATT are low temperature cautery, and if you don't have a low temperature cautery, you can have a heat cautery or the ball cautery, and you can just bring it closer to the cut end of the suture. So there is no role of this needle. Just cut off the needle of the 50 Prolene suture. You can use it, throw it away, and then just the suture. And one suture you can cut into many pieces of around 4.5 centimeter each, and then you can keep using it. The other one suture use in one case and then discard, another one keep cutting it and then keep it ready, mushroom it, and then keep for the other cases. And if you don't have ball cautery also, you can heat up a spatula, cyclodialysis spatula. This is what I learned from Siddharth. So you can just heat the spatula, you can bring the suture closer to the spatula, and then it will become a mushroom. So what is the logic behind making uh, mushrooming the tip is because it is a very sharp suture. It can create a false passage if it is not smoothened out, the tip is not smoothened out. So that is why we have to make the tip smooth, otherwise it will go in any plane wherever it wants. So low temperature cautery, if there, very good, not then heated spatula and heat cautery. A Helon GV, if you don't have, you can have Orogel, and you can have BioHylo, which is from Biotech company. So the point is, it should be 14 milligram per ml or 18 milligram per ml. It should be cohesive. Swan Jacob Gonio Prism, as Mahesh made it clear in his presentation, you can also have eye prism S, eye prism SX, eye prism OA, or Katina lens. They all have, and depending upon your you are a right-handed surgeon or a left-handed surgeon, you can buy the lens which fits in your hand. So it is a left-handed also, right-handed also. 50 Prolene suture. Some people use 60 Prolene also. So suppose if you feel that the trabecular meshwork of a patient is not of a normal width, you can go ahead with 60 Prolene also, like in children. Or if you feel that it is a broad trabecular meshwork, you can go with 50 Prolene suture. Then MVR blade, 25 gauge, you can borrow it from your retina people, or if you are in a private practice, you can just keep on ETOing it and you use it. MST forceps, which should be serrated, they should have serrations at the end, and McPherson's forceps, which is freely available. Patient selection, as Ganesh sir said, that this anatomy, where you can see the Swalby's line, the pigmented trabecular meshwork, the scleral spur, and the ciliary body band. So if you can see the scleral spur nicely in the nasal angle, you can go ahead with any angle surgery. But if an angle is like this, which you can see on the right hand side, it has got lots of pigment dispersed, pigments over the scleral spur also, and Schwalbe's line also is pigmented. So you intraoperatively you might get confused, okay, where should I give the nick? And if you go and make a nick in the ciliary body band, then you will have a cyclodialysis cleft. So before you start, Mahesh has covered intra gonioscopy, patient positioning. So, how do you position the patient? I was supposed to have some photographs here, but they are not there. Anyways, this is intra gonioscopy. Here on the right hand side, you can see I use HPMC. HPMC doesn't stay on the cornea, it just flows away. So don't use HPMC. Keep Orogel at your disposal. Keep two for one case because it will be just 2.5 ml, and before you know it will get finished. So just keep two on table. So this is the angle which you want to see. Start with a lower magnification, and once you are getting the view, then increase the magnification. You can manipulate the patient's head if you feel that no, I'm not getting the end fast view. So as you can see here, this is the view which we want. So patient positioning, correct positioning, I have tilted. I always do my mixed procedures with the head end of the table elevated, so it will be in a reverse Trendelenburg position so that the blood reflex from the Schlemm's canal is less. Then turn the patient's head away from you, tilt the microscope towards you. So I'll be showing you some intra-op complications. So once you give a nick in the trabecular meshwork, you will have reflux from the collector channels. Anyways, after doing phaco, if you are doing GATT, it will be filled with blood because of the hypotony which we induce during the phaco. So be prepared for that you will face some blood. So pre-fill the anterior chamber with Helon GV or Orogel. Keep the head above the heart and use high viscosity OVD. What if you have a false passage? To avoid false passage, you can use intracameral pilocarpine to constrict the pupil. Proper understanding of the angle structure is important, and you should blunt the tip into a little mushroom, not the one which you can see on the right hand side, which is a very large mushroom. So if you have a very huge mushroom which is out of proportion to the trabecular meshwork which we are going to feed it into, then definitely the suture is going to take some other pathway. And limited initial goniotomy, the 1 clock hour is enough. You should have some trabecular meshwork on both the sides. Suppose your anti-clockwise is not proceeding, then you have to feed it in the clockwise direction. So you should be seeing your suture going behind the trabecular meshwork. So that is why initial goniotomy of 1 clock hour is enough. And also you should confirm the suture pressure in the Schlemm's canal by doing an indirect gonioscopy. So you can see, so this is the suture, this is the blue color suture which you can see, this is behind the trabecular meshwork. So this blue color is also helpful in making you see where your suture is. So here you can see that till this point it has reached and this point is still left, this part. So you are assured that okay, I am not in any other plane, I am in the Schlemm's canal only. But if your suture doesn't advance any further and you are stuck up in spite of putting it inside, so how do you know how much suture do you need? Pre-measure the suture. So just make a loop of the suture around the limbus and just make a kink or mark it by making a small nick on the suture, so that you know this much suture roughly I'll be needing. And if that kink appears inside and still your suture has not appeared from the opposite side, then you are in trouble, that maybe it has taken some other pathway. So pre-measure your suture, confirm the suture in the Schlemm's canal, and you can do a twin side GATT or a clockwise GATT. So because I'm a right-handed person, it will be easier for me to feed it in a forehand fashion. But if somebody is a left-handed surgeon, they will be feeling better in putting it in a clockwise direction. So depending upon which handed person you are, you can start your surgery. And resistance is normally felt at 180 degrees when the suture has to take a turn towards the opposite side. So it's a good sign, but sometimes you can't just keep on pushing it and it doesn't appear. So just abort it and then feed it in the other direction. As Ganesh sir said, you might have shallowing of anterior chamber while doing, because you are not aware your left hand is keep on pressing because you are in so much of stress, because you want the suture to go in the proper position, and unknowingly our left hand presses. So we have to fill the eye and nicely with Orogel and then gently place your hand on the eye. And you can support your hand which is holding the lens on the forehead or on the cheek as per the laterality of the eye. Post-operative pulse, leaving Orogel in AC 30% or 40% fill, which acts as a tamponade. Do a very good pre-op counseling of the patient and tell him or her that there can be bleeding in the eye, but it is self-resolving. It will be resolving in a week's time, and also you have to sleep on the side of surgery for at least 1 week and with head elevation. So whatever hyphema occurs, it will trickle onto the temporal side, and the nasal side will be free for filtration. Post-operative IOP spike can be dealt with by using alpha agonists or beta blockers, and we use steroids and antibiotics. So it depends upon your center. If your bleeding is not too much, you can quickly switch over to NSAIDs, but if you have a lot of heme, then you have to continue steroids for a longer period of time. If time permits, can I show this video? So I'm blunting this is a low temperature cautery. So this is the one on the right hand side, which is a very big one. So I was not knowing how much to make it flange. So I used to make big flanges initially, and once my suture came out through the tube, so it gave me a heart attack on table. Then what have I done? And always all your incisions should be clear corneal, so that these limbal vessels do not trouble in the doesn't trickle under the corneal lens. Your view is unhampered throughout the surgery. And most importantly, this side put which I have made, your angulation towards should be the nasal angle. These are very small dips. While doing, if we can keep all these things together, we can have a good surgery. This is the relaunched Orogel I put on the cornea, which stays there. What prism I am using is eye prism OA. OA is open access. It is given to me by Globos. So this is the area where I am always making a small 1 clock hour goniotomy. So you can see, I can see my radicular mesh on either side of my goniotomy. So if my anti-clockwise doesn't work, I can go clockwise. These are empty first steps. And see, your suture is going behind the radicular mesh work. So you are in safe hands. Your suture is in safe hands, and okay, fine, I am in the correct position. But still, if I am having any doubts, I can have colonoscopy on table. Perpendicular, because if you are perpendicular, then it will push your suture into the suprachoroidal space. Now you can see the suture has appeared from the other side. It really feels very nice when you get the suture coming from the opposite side. Then hold the suture on top of the suture which you have used before, bring it to the center. That means that you are creating a goniotomy in that part. Then using your first scissors, you will take it out so that the inner wall will be cut 360 degrees. Then you can proceed with your fake home. So the take-home messages is moderate open angle glaucoma cases are the initial ones you should start with. They should be widely open angles. Pre-op counseling should be done. Practice intraop gonioscopy on routine phaco cases. Do a limited initial goniotomy. Feed the suture in the Schlemm's canal. Don't push it. Keep the head above the heart. Use liberal OVD. Use indirect gonio lens to confirm the suture position, and be patient and perseverant. Thank you.